All right, it's my turn. I don't know who put my talk between you and lunch. Um, I guess this is spot nobody wanted, so it fell on my lap. Okay, let's bring the slides up. Um, I have no disclosures. I'm a director of the Comprehensive Stroke Center at Maimonides, Vice Chair of Neurology. I'm a stroke neurologist by training. From some of my mentors over here, Dr. Levine, Dr. Rosenbaum. Those are my mentors, the giants in the field. I'm quadruple boarded in general and vascular neurology, neuroimaging, and then also neuroendovascular surgery. But today I'm going to talk about I think, provocative and controversial topic. It's about acute treatment with heparin infusion, unfractionated heparin, which has been falling out of favor for a long time. And there's some data from the old studies and also guideline recommendations really tells us we don't know the benefit and risk ratio compared to something like aspirin or antiplatelet therapy for acute stroke therapy. So in certain circumstances, it's not recommended. In others, saying we don't know. But I think it really depends on what patient population you are looking at, on what the condition and what outcomes you are looking at that really define the clinical trials outcomes. So I'm going to give him some data and a historic perspective, and also a future paradigm for you to consider. So I said this a dinosaur versus phoenix because heparin actually is one of the oldest drugs in modern medicine. It was discovered by a second-year medical students. For those of you who's in training, either as medical students, residents, or fellows, you could make remarkable discoveries even as a trainee. So remain curious and ask those questions and pursue your dream. So it was actually discovered by J. McLean in 1916. This is in comparison to penicillin was discovered in 1928 in London. So he's a second-year medical student working in Professor William Henry Howard's lab physiology at Johns Hopkins University, my alma mater. We have another faculty today, Dr. Philip Gayud from Hopkins as well. So Jay was trying to isolate a fat-soluble phosphatide with anticoagulation properties from a dog liver tissue. And when I was studying the molecule called cephalin, so Professor Howie actually named the molecule or the kind of a mixture of compounds as heparin because it's from dog liver. In the early 1920s, Professor Howe actually identified, purified a water-soluble. Remember, initially it's fat-soluble, then become water-soluble polysaccharides, the extract that with similar anticoagulant properties, then eventually it is also called heparin. That has to be detoxified and actually mass-produced for modern use, clinical use in the future. This is not until 1935 when Eric Jorpis from Karolinska Institute of Sweden, Stockholm, publishes molecular structures that led to its widespread clinical use until this day. Heparin is, I think, in my opinion, is the most widely used medication in modern medicine. It's so widely used, so long used, has so many applications. And the maximum action of heparin is through the ultrasulfated glycosaminoglycan or GAG mixture. There are two different types of heparin. One is unfractionated heparin, which is a mixture of 3,000 to 30,000 Dalton kind of mixed bag of molecules that are water soluble, which are highly negatively charged because of the sulfur group that will bind to activate antithrombin, which is a serine protease inhibitor, which in turn inhibits the cascade initiator cascade, a catalyst of the clot formation thrombin through the simultaneous inhibition of both thrombin production and also thrombin activity. So it's very effective, very quick action. Heparin actually does not dissolve clot, contrary to many common beliefs. It's actually preventing new clot from forming, sort of tipping the balance towards anticoagulation, kind of carried out by your endogenous thrombolytic cascades in the body, such as TPA. So it's synthesized and extracted from porcine, opaque intestine mucosa, which actually produces less HIT syndrome, heparin-induced thrombocytopenic thrombocytosis in large quantity in the US, but can be extracted from cow or porcine lungs elsewhere in the world. So it's available in two forms. The other form is a low molecular weight heparin, such as Lovenox or Fragment, which is typically a mixture of 4,000 to 6,000 Dalton molecule mixture. So this also, beyond the most widely used medication in modern medicine, is probably also most studied one of medications or molecules. Actually, if you Google PubMed, as of this morning, 6:30, I was working on the slides, talking about procrastinators. So there are nearly 300,000 publications related to heparin, with over 66,000 grants associated with this molecule. So beyond anticoagulation, which is really a tip of the iceberg for the pharmacodynamic or pharmacokinetic activities, it had anti-tumor activity, anti-inflammatory, antiviral, antioxidant, and other pharmacological activities through different kinase pathways and spike proteins and MEP kinase, VEGF, affecting the vasculature in different ways throughout the body, right? Different organs. And then, of course, there are side effects, mostly bleeding, thrombocytopenia, also can cause elevated transaminase as well, besides allergic reaction. Those are the typical side effects we can encounter that can affect the outcome of studies. So again, clinical applications are very wide, including essentially any clotting situations, PE, cardiac, or DVTs, mesenteric, or myocardial infarction, AFib, or prophylaxis for DVT, post-surgery, or bridging therapy in between someone doing procedures while on anticoagulation. Interestingly, one of the paradoxical use for heparin, the high dose actually unfractionated heparin use with PTT between 80 to 100 is cerebral venous sinus thrombosis. Even in those cases that are actually having secondary hemorrhage from the sinus thrombosis due to venous congestion and obstruction, heparin still is indicated and safe by and large. So that's a sort of a counterintuitive usage of that. So what does the guideline say for heparin use in acute stroke therapy? And this is the latest. I think we need another update pretty soon. American Heart, American Stroke Association guidelines for acute stroke management. In the guidelines for anticoagulation, it says the usefulness of urgent anticoagulation in patients with severe stenosis or of internal carotid artery if lateral to the ischemic stroke is not well established. The safety and usefulness of short-term anticoagulation in non-occlusive extracranial intraluminal thrombus in the setting of acute ischemic stroke are not well studied or established. The usefulness of agachoban, the Bigtran, or other thrombin inhibitors for the treatment of patients with acute ischemic stroke is not well established. It goes on. And then on the bottom, so it said urgent anticoagulation with the goal of preventing early recurrent stroke halting neurological worsening or improving outcomes after acute ischemic stroke is not recommended for treatment of patients with acute ischemic stroke. So at best, we don't know whether it help. At worst, it could potentially harm. So that's the latest guidelines 6 years ago, which we don't have update. We cannot talk about heparin stroke without talking about the TOAST trial, which you have heard before that actually define the etiology, the different categories of stroke etiologies, cardioembolic stroke, large vessel arterial embolism, or extracranial, or small vessel disease, lacuna stroke, so to speak, or cryptogenic issus, or unknown, right? So in the initial trial, we actually studied the heparinoid called the naproid, and for acute ischemic stroke in 1990 to 1997. So in that study, that actually give the patient 7-day course of the heparinoid, and in the 1,200 patients in the population with acute stroke, across the 36 centers in the United States. It took about 7 years to complete the study. In that trial, compared to placebo, when initially gets bolus with 24 hours, within 24 hours stroke, followed by continuous infusion. And the main outcome is favorable outcome, rated as a combination classical coma skills, 1 or 2 on modified Barthel index. Not exactly the same as the modified ranking skill we use these days, but similar functional skills. At 7 days and beyond. So at 3 months, so there are no big difference. But at 7 days, so there is actually a difference, close to statistical significance, of favoring actually the heparinoid group compared to the placebo group. The statistical significance p-value is 0.07. It's very close to the 0.05 significance. For the same interval, if you talk about just the favorable outcome, but if you talk about very favorable outcome, it's actually very significant, 0.001, 0.01, actually favoring anticoagulation. So for a very good outcome patient group, actually heparin was better than the placebo. But the conclusion based on the trial is that despite an apparent positive response treatment 7 days, long-term benefit beyond that 3 months is not clear. So it's not associated. That, I think, basically killed any future studies of heparin usage in acute stroke therapy. But I hope you would agree with me, there's a signal in there at the acute phase, there's benefit, and they actually can have great outcomes. So why did the trial actually at 3 months turn out to be negative? I think that's because partly because the trial included all the patient population, large vessel, small vessel, cardioembolic, and arterial embolism, everything in there. So heparin may work probably the best in those with thrombus as opposed to small vessel disease. So if you have everything in there, you may not see the signal, right? Acutely, some of the benefits may be exacerbated by the large response from heparin responsive group, but can be washed out with longer term with smaller other groups. That's my hypothesis. So there's another pivotal trial that led to the paradigm for acute ischemic stroke in large vessel occlusions. This is probably one of the earliest actually positive trials using pro-urokinase compared to heparin intraarterially to see the difference, whether there's reconnaissance and improved outcomes. The ProAct2 trial from 1996. This is shortly after TPA was approved, led by the study from Dr. Levine and others by the FDA in 1995. So in the ProAct2 trial, 180 patients had actually angiographic proven confirmed occlusion of MCA, middle cerebral artery, large vessel occlusion, without hemorrhage was randomized to either 9 milligram intraarterial prourokinase plus heparin or heparin alone. In that study, actually, for the primary outcome analysis, modified ranking scale at 90 days with 2 or less, is 40% of prourokinase patients actually did well, compared to 25% in the control in the heparin group, right? It's statistically significant. However, pro-urinary use never approved for use in the United States, I think partly because of political reasons and other financial reasons. Mortality was similar in both groups, and reconciliation was higher with the combination of pro-urokinase and heparin. But keep in mind, there are 25% patients with heparin actually doing pretty well. And these MCA patients, large vessel occlusion patients in general, do not have that degree of good outcomes, not by natural history. And also, there are 18% of the control group actually recanalized. Not as good as a 40% or higher, but actually 60% or higher by the pro-urokinase. But heparin did help with large vessel occlusions too, right? So there's no significant differences. Hemorrhage is about, actually there's 10% versus 2%, but it's not statistically significant for hemorrhage or complications. So again, this signal in the Acute trial for heparin to have benefits may not have reached the statistical significance because of the small size, but it's there. So that's why I said heparin use in acute stroke therapy has been like the dinosaurs, and old and dead, if not dying, right? It's mixed with all kinds of different creatures in there, not just a single species, right? So nobody really used it in the clinical trials, or clinical studies, or clinical use in a large fashion. But I think if we can define a population and define the outcomes in a different way, potentially we can find utility from that. And today I'm going to actually give you a few examples of proof of concept clinical cases for you to think about. And none of these patients had any worse outcome or complications. And some of the clinical outcomes are unbelievably good, and to my surprise, after 20 years of practice. So this is actually some of the cases, 25 cases, and 3 of them we have published, actually submitted for a poster presentation in last year's Society of Vascular Interventional Neurology, and first authored by one of our PGY3 neurology resident, Jack Gurzy. I don't know, he's online. Good job, Jack. He's actually matched to a stroke fellowship at Westchester Medical Center and interventional fellowship at South Island, Long Island Medical Center. So he will become one of the interventionalist neurologists like me in the future. And of course, we have our longtime collaborator, Dr. Daniel Masri, Director of Neurology, who helped us with the imaging acquisition. And he reads all the images as we do. So the first case, proof of concept, is a 62-year-old, actually Maimonides employee, smoker, hypertension, prior colon cancer in remission. He basically collapsed in the lobby of Maimonides 10:15 in the morning. So witnessed symptom onset with left gaze deviation, global aphasia, right hemiplegia, and at age 27, essentially a clinically acute MCA or internal carotid artery syndrome on the left side. And the CT has shown no bleed, no traumatic injury, and the CTA demonstrated. You see, this is the right side of the carotid artery goes intracranially, and the vertebral artery in the back intracranial are fine, left side is dominant, and the carotid artery you can see from the get-go the origin of carotid artery compared to the other side is dissected and partially occluded. Much smaller caliber, and you can see the internal carotid artery is completely occluded all the way until the skull base, intracranially with retrograde flow coming from the anterior communicating artery and with diminished flow. If you look at intracranial flow from the CT angiogram, actually the MCA bifurcations are patent, shown over here on the left side, but it's just diminished flow. You don't see the flow as extensive as on the right side. The CT perfusion demonstrated large penumbra and actually large territory infarction based on the rapid criteria. But there's substantial mismatch, clinically symptomatic, right? So large penumbra, large core. So here's your question, if you're falling asleep. So what is your treatment choices, right? Should we give him TNK? Early onset, witnessed, he got to ED within 40 minutes, right? So the reimaging is done at 10:58 from 10:15. Eligible after the fall, carotid dissection, large clot, and the vascular therapy, mechanical thrombectomy, or TNK plus thrombectomy, or heparin infusion, or something else, aspirin, single monotherapy, or observation. We don't do things like pediatrics to observe. We treat with someone like acute signs like this. So what is your answer? By show of hands, who select A in the audience? Dr. Levine. Right, so people with known carotid dissection, we know potentially could be safe, but he had a lot of clot burden, right? From a common carotid origin all the way into intracranial of the skull base. Will TNK dissolve the clot? So they're probably not by itself, because study has shown that actually the chance of that happening is less than 5% for even intracranial portion, let alone the cervical carotid. There's so much burden, so much substrate for the clot, for the enzyme TPA to work, right? If it doesn't work, why do we give it? Because our role is open the vessel, right? Mechanical thrombectomy. Anybody? Barbara. Good. Yes, one of the residents. So to do mechanical thrombectomy, I feel I have to actually secure the proximal carotid artery. I may have to stent it from all the way from origin into the internal carotid to secure that to go through the clot. That requires aspirin Plavix, or actually 2B3 inhibitor loading intraoperatively before it can go intracranial, plow through that much snow to actually open that vessel. But keep in mind, this patient, intracranial vessel is open. It has diminished flow. If he does have a left MCA occlusion, the story may be different. I have a case to show you afterwards if you have interest or have time. So antiplatelet therapy, in my mind, doesn't have a lot of roles in acute therapy. Can provide secondary therapy, secondary prevention, good. Have minimum function for acute prevention, acute recognition. So what we did was we start heparin infusion with PTT 50 to 70, and admitted him to the actual ICU, monitor him. So he came in on April the 18th. 5 days later, you can see the complete recognition of the entire carotid artery. The caliber is not 100% compared to the right side, but you see actually much better recognition, the healing process for this patient. And the follow-up study showed complete restoration, just like the right side, right? And this is the diffusion with imaging. At the same time, you see some hemispheric signal hyperintensity, but not really bright, different cuts. 2 months later, it actually normalized, and there's minimal flare signal changes for long-term damage. And this is him I ran into him the other day, actually. He's still working full-time, no deficits. Modified ranking 0. Managed stroke skills 0. Right? Every time I run into him, he give me a hug. You saved my life. I said, I didn't. Heparin did. A second case, a medical actual resident from Maimonides. We treat our employees really well, like a family, you know? Young person, nothing happened, just some URI, viral illness, and multiple coughs, bouts, and then basically had headaches. And we did a study, lo and behold, we see a dissected internal carotid artery, a CTA. And we started heparin drip. This is 3 days later, you can see recurrenzation. And 2 months later, complete recurrenzation. And intracranially, there's patent flow. And his clinical scores remain same, 0. So if you enroll this patient in the trial, you will not see the benefit if you give aspirin or the things, say spontaneous recurrentized, right? Because he never was symptomatic. But if you used recurrenzation, acute recurrenzation as your primary outcome, you will see the difference. When vessels are occluded, don't we want it open back to the normal stage, just like 2 months later? And now heparin offers a reasonable, safe, effective alternative without complications, with N of 2 so far. Okay? I want you to think about this. This is a proof of concept. Can be done just like thrombectomy. Initially, we were told, because the trials is done differently, that it's not effective. But once you redesign the trials, select the right patient, use the right tools, treat them effectively early on, the story is entirely different, black and white. So actually, this is backwards, but I'm just going to show you this first. Third, you can see the 6 o'clock in the morning, I wasn't awake yet. The third case, this case involves symptomatic vertebral basilar steno-occlusive disease. 75-year-old lady came in, basically with new onset dysarthria, automental status, and then she's 4 initially, but in the course of during the ED, she became obtunded. And she wasn't having a seizure, she wasn't shaking, doing anything. But because she had a occluded top of basilar, right? So lots of normal really not clear beyond the TNK window, anything. And the only thing you can left with potentially thrombectomy, go in to retrieve the clot or reopen the vessel. But how? Look at the CTA proximally. The proximal steno-occlusive disease chronically. I wouldn't go through this. Dr. Gayu, you will go through this? So there's no way to get intracranially. But she's having a hypoperfusion, brainstem syndrome with basilar. She's comatose. What will you do? The same choices of treatment. What will you do? Well, we're having a heparin talk, so heparin is the answer I picked going forward. Infusion, remember unfractionated heparin, not Novanox. The molecular mixture is different. PTT, we don't want to be too high, causing secondary hemorrhage. So in that range. And she woke up shortly after we started the heparin drip. Just like someone who had a seizure, you give Ativan or Keppra, they wake up because they are reestablishing the basilar artery flow again, right? And we transitioned her to DOX, and she was discharged home. She never came back for follow-up, for compliance, but maybe because she's so good, I hope she didn't die. So I won't bore you with all the additional cases, but these are the 2 vertebral artery dissection cases that happened last week when I was on service, that both recanalyzed with heparin infusion, right, within 2 or 3 days. One is young, one is old, CTA perfusion. Very effective. None of these people had any side effects. But some of them had actually stroke. One of the ladies has cerebral strokes. We anticoagulated her just fine. So we can't talk about heparin and aspirin without talking about the CADIS trial, which basically you can read from here, comparing heparin followed by warfarin, which is antiplatelet therapy, randomization. So in this CADIS trial, the conclusion is that the recurrent rate, stroke rate at 1 year was similar. There's no difference, right? There's no difference of recognition at 3 months either, or residual recognition based on that trial. So it's a negative trial. Heparin is not better. It's not worse compared to side effects. There's another trial called Treat CAD. Again, anticoagulation, antiplatelet therapy, slightly different design, but you can go through that. I won't go through the, don't have time to go through the details of design. This showed actually, did not show that aspirin was non-inferior to warfarin or anticoagulation. Not heparin, but yeah, in the cervical carotid artery disease, including vertebral or carotid disease, right? So not non-inferior. So it's a double negative, go figure. But when you combine these two together, right, a pooled meta-analysis showed actually odds ratio favoring anticoagulation over antiplatelet therapy. Again, this is anticoagulation with coumadin and heparin bridging, but it is, there's signal there, right? So the future time paradigm I'm proposing for you to consider, which needs large-scale randomized trial to verify in prospective fashion, is to consider unfractionated heparin use infusion in acute stroke therapy if you are dealing with acute vascular occlusion, partial occlusions. I have 3 or 4 basal artery occlusion cases that recanalized, and severe stenosis with trickle flow or vertebral vascular occlusion disease, not candidate for TNK or thrombectomy, in addition to vascular injuries. So I hope this provides a glimpse of hope for heparin to be reintroduced into clinical medicine and in acute stroke therapy, like rise of phoenix from the ash. I'll stop here, take questions. Thank you. I'm sorry that we went over. We'll leave you with 5 minutes for lunch. We'll skip the questions, go grab lunch, and then we can continue if anyone has questions while eating, and we'll go from there. Go visit the exhibits too.